Hi, my name is Corey Clem, and I am a National CMV Foundation Community Alliance Chair. With us tonight, we have two guests. We have Dr. Brophy, who is a clinician investigator at the CHEO Research Institute and an associate professor in the Department of Pediatrics, Faculty of Medicine at the University of Ottawa. Dr. Brophy completed his medical degree and his pediatrics residency at Memorial University in Newfoundland, and his infectious diseases fellowship at CIHR Canadian HIV Trials Network postdoctoral fellowship at the University of Toronto. He also earned a master's degree in health research methodology from McMaster University and a diploma of tropical medicine. He has a special interest in CMV research and has been a driving force behind Ontario's universal CMV screening program. Dr. Karen Fowler is a professor of pediatrics, infectious diseases, and epidemiology at the University of Alabama at Birmingham. Her research is focused on the natural history and pathogens of maternal and congenital cytomegalovirus infections and CMV-related sensorineural hearing loss in children. Dr. Fowler was part of the NIDCD-funded CHIME study that screened over 100,000 newborns for congenital CMV infection. New findings from the study included developing a highly sensitive and specific PCR-based assay for testing newborn saliva samples to identify babies infected with CMV and further understanding of the rates of congenital CMV infection and CMV-related hearing loss in the United States. She has also investigated targeted clinical CMV screening in infants who do not pass their hospital newborn hearing screenings. In addition, Dr. Fowler serves as a scientific advisory committee of the National CMV Foundation and is working with the foundation to promote universal CMV screening in the United States. So we are in June, which is our national or our CMV awareness month. Our big push for this month is that we want universal screening for CMV. So our theme this year is Screen for CMV. And I have a little bit of a personal reason of why this was so important is our daughter Ellie was born with CMV. And if it had not been for some very, very in tune doctors, she would have completely missed being identified as a CMV baby at birth. And she would not have received her antiviral treatment at 5 days old. And so because she was caught by a doctor, we had several people in there who couldn't figure out why she appeared healthy, but had petechiae and then low platelets. And so for us personally, that universal newborn screening would have been crucial for her because she could have easily been missed because she was otherwise healthy. And we don't know where her hearing would be at this point. She's currently single-sided deaf, just received a cochlear implant, and we are so thankful that we received that intervention early. But again, she could have easily been missed. And so that's why we think that universal screening is so important for all infants. So welcome to our two guests. We are going to jump right in with some questions as soon as they pull up. So first question is, why do we have newborn screening?
I can try. So newborn screening in general, like not specific to CMV, but generally is to identify conditions that are present in the newborn period that are actionable, that we can do something about, and that have the potential to cause harm to children. So in Ontario, we have screening for 30 different conditions. It includes metabolic conditions, sickle cell disease, cystic fibrosis, severe combined immune deficiency or SCID. And just in the past year, the past few years, we've added CMV as part of newborn screening because there's something to do about it. Dr. Fowler, I'm not sure if you have anything to add to that.
No, I think that's great. I mean, and one thing I'll say, Jason and Ontario, is that they're probably the only place, I think, in the world that are doing CMV, universal CMV screening, right? I don't know of anybody else that started. So that's incredible. And they linked it in with the newborn hearing screening. So, all babies in the United States get newborn hearing screening, but only a few. I mean, the clinical suspicion was like what happened with your daughter. Thank goodness, like you said, you had some really on the ball doctors who figured it out before she went home, and everybody said, oh, her hearing's fine and whatever. And then you find out later. But CMV screening, and then some places are doing what they call targeted, where if the baby doesn't pass the newborn hearing test, they'll get a CMV test. But most places, nothing happens, especially for a baby who may have no other symptoms and who just sort of gets missed in the newborn nursery because they look fine, but then they develop hearing loss later, or even maybe have mild hearing loss that gets kind of missed on the newborn hearing screening also. So I think what's happening in Ontario is really exciting for all of us in the field, and it can be an example of what we can strive for in the United States.
Great. Okay, it looks like we've got some more questions coming in from Facebook. So this next one is, what criteria are used to determine which conditions newborns should be screened for?
So to my understanding, there in the U.S., there's a committee that decides what can and can't be added to newborn screening. In Canada, we're a little more jurisdictional when it comes to health, and so that's done on a province by province basis. And so these committees decide which ones are the ones that should be added or that are already on. It all started with PKU, or phenylketonuria, which is a metabolic condition that we know if you don't do anything, it can damage the baby's brain and their development. But if we just make some dietary changes, they can have normal neurodevelopment. So that started it all. And now we have these committees. I apologize, I don't remember the name of the committee in the U.S. It's
the RUSP.
RUSP, yeah.
RUSP, yeah. And so they do that, and they make a decision. The states can decide to take up those conditions or not, and most states do whatever the RUSP recommends. But obviously, we have a little state jurisdictional things that go on also. But right now, RUSP has not said that we should do CMV screening. I think the National CMV Foundation is putting forth an application to ask them to evaluate and try to get all of the data that we need to put forth to do that. There have been some challenges, but I think we've got very committed parents and scientists and clinicians who want to see it happen.
Great. Okay, so our next question is, should we screen all newborns for CMV? So there's some criteria that may or may not need to be met, but do all newborns need to be screened for CMV?
I'll answer that first because that my answer is going to be yes, of course, why not? But no, you say, well, what about, some of the kids are not going to have any problems or whatever, but we don't know which kids those are. And so we're missing kids. So in the United States, I think we have 3.6 million births a year, annual births. So if we have 5 per 1,000 babies, or 1 in 200 babies born with CMV, we're having 49 babies, is it a day, born? And so some of them will be evident at birth, but a vast majority are missed. And we see very often a child, and it's not all children, it's a number, but who pass their newborn hearing screen. They don't have any symptoms at birth. They're fine. And if they have a hearing test at 3 years of age, they're fine. Then suddenly they show up at 42 or 48 months. If they need to be followed, the problem is they aren't being followed, but when they are in our studies and things, they will have suddenly a moderate to profound hearing loss. So those kids, so what happens is parents call different, and all over the country, they call and say, my daughter, she's fine, but suddenly, we noticed she was turning the TV up, or we could hear her sounds through her headphones, we're like, turn it down. She's like, I can't hear. And so like a 5-year-old will have like a unilateral hearing loss, and they're like, could that be CMV? And we're like, well, it's too late now to know for sure, because we need to test the baby in the first 3 weeks of life to be certain. So I think that's why we screen, and then they can have the interventions, like you said, antivirals, and then also even more importantly is early intervention. so that we know. I mean, and that's a treatment, the same thing happens with newborn hearing screening. You can't erase the hearing loss already, but you can start to intervene and make that, a much more manageable situation for that child and get them mainstreamed into the world, which is what all parents would want for their kids. And Jason, you may have some more to add. I jump right in on universal CMV screening.
No, I'll try to add on. So obviously we think so in Ontario for all the same reasons that Dr. Fowler mentioned, in that we know that 10 to 15% of asymptomatic kids will go on to have these development of hearing loss or developmental delays, and then the symptomatic ones will go on to develop it like even more commonly, like 30 to 50% of the time. And there've been a couple of studies in Canada that suggested that even now we probably only find 10% of the symptomatic kids. Like we're only finding about 1% of them overall. And so this gives us the opportunity to find all these kids who could benefit from the follow-up that we have in place. And so we feel strongly that this is appropriate. And you always have to ask, well, are there any harms? Are there harms to identifying babies? Because if we know that 75 to 80% of them will be completely normal and not require anything, is that worth the added stress and worry to the parents? And when we speak to people and we ask their opinion, they almost all say they would want to know. Like it is a stressful thing, but they still would rather know than not know.
Okay, great. So our next question is, how is screening for CMV done?
So I can tell you what we do here in Ontario. So we've added CMV testing onto the dried blood spot, so that those 5 drops of blood that they take and put on the filter paper after the baby's born before discharge home, or if they're born outside the hospital, that is hopefully done in the first few days of life. That's where we do the CMV testing. I know in other places where they have targeted screening, like say a baby who fails their hearing test before they leave the hospital or soon afterwards, they can have testing done through other ways, either urine or saliva testing. And so those are the options. And I think it depends on what's in place in your own jurisdiction in terms of what test is done. But see, either blood or saliva or urine. We know urine and saliva are way more sensitive because there's about 100 times more virus in those fluids than in blood. And so that's probably the best method. But because in Ontario, we take dried blood spots for other screening tests, that's easy to add it on.
Great. And then Dr. Fowler, did you have anything to add on that one?
No, I think Dr. Brophy's correct. I mean, a lot of places are doing targeted. It's very easy to get a saliva swab and do that in any hospital. I mean, there's also labs around that can do this, but any hospital that's doing any kind of CMV PCR for like transplant patients or whatever can do these tests. So it is possible to have it done. And urine's a little bit more difficult to get from a small baby because, we all know that. So saliva, just putting it in the cheek and leaving it for 45 seconds is really easy. Yes. After 3 weeks, people can try in the United States to get their dried blood spots if it wasn't available at the time. And each state has all kinds of rules about that. Some states don't store them very long. Some states will store them. Some are able to let their ENT or their physician get them. I think most states probably don't pass them out to parents, though I could be wrong. So it's a little complex. So it's much faster and much easier to do it while they're in the hospital. But I think the infrastructure is there for, like what Dr. Brophy said, for the dried blood spot. So it works, it makes it possible to have happen.
Yeah, they're already there doing the other one. So it's a very easy
It's a little different test, but the point is at least you're not having to worry about the infrastructure, because now you've got to figure out how do you get saliva samples. That's not an impossible task, obviously, but
Yes.
it's something, because obviously in the United States and in Canada, we added newborn hearing screening, and it's not obviously the same test as the dried blood spots, right?
Yes.
So it is possible to add different things, but it just adds another layer of complexity.
Okay, great. So with that, how accurate is CMV screening?
That's a good question. And
Are certain tests more reliable than others, or?
Yeah, so like I said, we know that urine and saliva have way more virus in them, so they are more sensitive tests. Saliva can be a little complicated if the baby's breastfeeding and the mom has CMV, and the CMV can be in the breast milk. And so if you swab the baby's mouth after they've breastfed, then you don't know whose CMV it is. But if we wait at least an hour after she's finished breastfeeding, then it should be reliable. But the dry blood spot testing, that's a bit of an open question where there's a lot of different estimates in research studies of how sensitive it is. And I think it really depends on the technique too, but it's probably somewhere between 30% and 95%. Somewhere in there, and it depends on the lab and exactly what they do with that dry blood spot test. And here in Ontario, that's one of the questions we're really keen to answer, because we have a certain percentage of kids that are positive on their dry blood spot test, but we don't know what proportion that is of the total, because we're not doing the gold standard urine or saliva test on everybody. And so we might be picking up 50%, we might be picking up 80%, we might be picking up 95%. We do know that we have found some babies who've had negative dry blood spots, but still had congenital CMV confirmed, because we found other symptoms, or they had a urine test in addition to their dry blood spot test, like say the mom tested positive in pregnancy. And so we know it's not 100%, but we don't know how sensitive it is.
Right.
We'd like to.
Yes.
Right. That's where we're all waiting anxiously for Canadian results. So we're all cheering for them. And I think too, for saliva, we've done some studies of about 100,000 babies in the United States. And so we know that the sensitivity on some of the PCR testing is pretty high. And it's mainly because, like Dr. Brophy said, there's lots of virus, and a baby that has congenital CMV is going to shed virus right after birth. And there's that challenge of the breast milk and managing that. But what I'll say is that anytime you have a baby screen for CMV, it's very important to get a follow-up, a diagnostic test, because if you're doing screening, the goal is to get you want to include as many people as possible. Even if you're getting a false positive, you want to bring them all in. And then the diagnostic is when you want to get rid of all the others, so that you've got the true infections. And so that's very important, that even if you get a saliva test and it's positive, it needs to be followed up with a urine test to confirm. And I'm sure in Canada that after a DBS positive, they're getting a confirmation of urine or saliva or both. So I'm guessing. I think I'm 100% certain on that.
You're 100% right.
All right.
Great. Okay, so our next question is, how much does CMV screening at birth cost?
A great question.
I'll let you go ahead.
So it looks like it could be economically feasible, but the challenge is we have a lot of missing pieces of data. It would be really great if we could start universal screening and gather that information, but obviously it's sort of a chicken and egg kind of thing. Policymakers are like, well, what is it going to cost us? And we're like, well, we don't really fully know, because we don't have everybody in there. But the data suggests we have to make some. So what I mean by that is then we're having a scientist to do some modeling and to look at sensitivity analysis, like looking to see if we change this variable, does it affect this variable? But I don't have the numbers with me. I wish I did right now, and I'm just kind of gone blank on the numbers. But it seems like it both universal and even targeted can be cost effective. Now, in the United States, we have a very robust insurance system. Medical insurance. And so, what it actually costs to do it in the lab and what your insurance may charge you is different. And I don't want to go down that path because I don't understand any of that at all when I get my own bills from my medical care. So I have no insight. So I can't help with that. But the thing is, when we use the data to look and says it's cost effective, we're basing on what it would cost in the lab to do it if you could do large scale screening. Canada's a little bit different, and a lot different. But so it's kind of a tricky question, and we really need better data. But we think preliminarily it can be cost effective.
Yeah, so I know that Soren Gant, who's a colleague of ours and who's done a lot of research in this field, did a cost effectiveness paper that suggested that the cost effectiveness, that the cost of identifying a case using universal screening was like somewhere between $2,000 and $10,000 per case, and that for targeted screening it was much lower, and that usually for cost effectiveness, if it's under $50,000 per case, that's like a good argument to say that it's a cost-effective thing to do. But the problem with that paper is it was theoretical. It wasn't based on real-world data, and that would be the ideal. And every healthcare system has different costs. Like an MRI in Canada might cost different than an MRI in the US. And putting a program in place like newborn screening or targeted screening might cost a different amount in a different place. So really depends on country by country or state by state, province by province. But any way you slice it, it looks pretty cost effective in that if we can prevent one child from having the developmental delays related to hearing loss and get them hearing augmentation or cochlear implants and preserving their learning, then we know that that's a cost-effective thing to do.
Okay, great. Okay, we've got two questions that I'm gonna kind of combine, but when does newborn screening for CMV need to be completed, and can they be tested after 3 weeks of age?
Yeah, so like Dr. Fowler mentioned, we like to, well, the definition of congenital infection is, it means that you've identified the infection before 3 weeks of age. And so we want to do that. And if we have a positive dry blood spot, then we can say, and it was collected at birth, then we can say it was a congenital infection if it's confirmed later. If the baby has a CMV test after that time, like say they had their hearing loss identified and then they got tested for CMV at 2 months of age and it was positive, and they weren't able to go back and look at the dry blood spot, or the dry blood spot was negative, but you're convinced that it's still CMV, you can say, I'm confident this is a case of congenital CMV based on how the whole case looks some of the time. But yeah, the ideal would be before 3 weeks of age to find CMV in one of those tests that we talked about.
Great.
And I think there's a second part of the question that I'm forgetting.
That kind of did just the 3 weeks and kind of what happens if it's past that 3 weeks, I guess. So yes.
So a lot of times, yeah, just to comment on the 3 weeks, it's so important. A lot of times, like the ENT will see a child who's referred on newborn hearing screening, but they don't make it to the ENT till maybe, it's supposed to be our program in the United States. They've actually, it used to be 1, 3, and 6. So, identified by 1, and then, and you've got intervention by 6. But so what happens is your kids show up at 4, 5, 6 weeks at the earliest, often at the ENT, and they're trying to figure out where the family has no family history of hearing loss, and they're trying to sort this out. And so unless they can go back and get that dried blood spot, it's a questionable, like it could be due to CMV, it could be some other reason. And it's sort of, and even if they test positive at that point, you can say it's it's congenital versus acquired. And so it just always has that. And acquiring CMV in the first weeks of life, a healthy infant isn't going to have hearing loss from that. It's the congenital infants, the infants that are affected in utero, during the pregnancy, the fetus that gets impacted, those are the ones that may have problems later with their hearing.
Okay, thank you. What are the benefits to screening all newborns for CMV?
Well, to my mind, the benefits are early diagnosis of problems and early intervention. And so, like we said, hearing loss is the main outcome of interest with congenital CMV. I mean, there's lots of other things that can happen, but in terms of our wedge to get in and act, or our way to get in and advocate, is, I think, hearing is the best one. And if we identify a child with hearing loss early, then we can give them hearing aids or cochlear implants to preserve that ability to learn, and prevent developmental delays as much as we can. And so that's the benefit of identifying babies with congenital CMV, is being able to find all those things as early as possible. And I always say to families that if we find this, it's nobody wants to have anything wrong with their baby. Everybody wants to have a healthy baby who has 100% potential. But by finding this as early as possible, if it is there, and being able to intervene as early as possible, then we're going to give that child the best possible chance to achieve the best that they can be. And so I think that that's a great thing.
I agree totally.
Yes, I fully support that as well. So that has been our experience. What are the drawbacks to screening all newborns for CMV? And I know that you guys touched a little bit on this, but I mean, any bigger implications for screening all newborns?
I know all that we've said, but I think we talked about, we don't know the cost yet per se. You could say that could be a cost to, whatever to that. But and also, I think Jason touched upon it. We have this concern that parents will be stressed by screening, and it's possible that some parents could be stressed if they didn't really understand why you were doing the CMV screening. So I think we have to have clear communication. But the vast majority of parents that I've talked to who only have first heard of CMV when their baby's in the neonatal intensive care unit or in the hospital says, why didn't I know about this? And, why didn't anybody tell me? And so I think as we raise awareness, which we work at, and as we screen more babies, even if they don't have hearing loss, and have CMV, hallelujah, that's great. So that's important. We'll raise awareness. But I think so I don't think that's a good argument anymore that they may be, that could be a drawback. I'm just saying that some people would see that as a drawback. I personally think we have to put it in the parents. Parents are really smart. And, let's put it out there and let them make decisions for their families. But so that's where I'm at. But some people have said that's the drawback, or that's why they're hesitant, because, there'll be a lot of them that won't have problems. So what should we do? But anyways, I can't think of what else, Jason. I can't think what else I'm so pro. I can't hardly think of a drawback.
Yeah, I mean, there's some kind of research that talks about like the medicalized child, or if people see their child as having this problem, then they kind of view everything through that lens, and maybe they're going to protect them too much and not let them experience life, or everything will be seen in this way. But like Dr. Fowler said, I think it's really important that we give that information to the families. It's not us to decide, oh, you don't need to worry about this, or you do need to worry about. We're here to help, and I think we can only help if we give them the information they need.
I love that. I hadn't thought about that being part of the universal screening, how much more awareness that would create. I hadn't even thought about the backwards effect of that. So I love that.
If I could just add one thing on to what Karen said, one of the things that I find the most striking in doing this work is of all the babies I've seen and their families, I can think on this hand the number of times that families had heard of CMV before their baby was diagnosed with it. Mm-hmm. And they all say the same thing. Why didn't I hear about this before? And when we think about all the other things we talk about during pregnancy, every woman knows that she shouldn't drink alcohol during pregnancy. The majority know they shouldn't change cat litter during pregnancy. We test for HIV and hepatitis B and all these other preventable illnesses. But we don't talk about CMV, and it's the most common congenital infection. And so I think awareness is key, and that's where the National CMV Foundation and CMV Canada are doing essential work to really get the word out and have people be informed and know what to look for their child.
Absolutely.
And I will say, and this is completely off topic, but if you, for people in the audience who've never met a child that has CMV, they are the most beautiful kids I think I have ever seen. They all have such charm, no matter what they're struggling with or how they're doing, and some are not struggling at all, and they're delightful. So it's not something to be looked down upon. It's a chance to really be aware, and I know it's a challenge for many parents to go through, but the children are just lovely. That's all I can say. Corey, your child, I met your child yet, but I think they're lovely.
The funnest, wildest 21-month-old you've ever met. And so CMV has not slowed her down one bit. So she's got that cochlear implant, and I think it made her bolder. We keep finding her trying to climb out gates and stuff. So, and she's the funniest. Everybody said she's the funniest kid you've ever been around. So we would agree with that statement.
I look forward to meeting her in the future.
Yes.
After we get all of our COVID time outs finished.
Yes, exactly. Well, we're going to go ahead and wrap up, but thank you guys both so much. This was fantastic information about screening for CMV and why it is so important, and why we need to keep pushing for universal screening, or at the very least targeted screening. So that's what that's kind of been my goal, is targeted screening. So thank you guys so much, and thank you to those of you who joined in on Facebook tonight.
Great. Thanks.
Thank you
so much.